Dear friends, this is an integrated lecture on carbonic anhydrase enzyme as its inhibitors and its therapeutic utility. The material is prepared as per the available literature. At places there could be reflection of the experience gained, and therefore it should be considered as presenter's opinion only. The contents are divided into parts. Initially, there is biochemistry, physiology, and then pharmacology on carbonic anhydrase inhibitors. Uh, Finally, I'll discuss the therapeutic utility in medicine and allied sciences. The objectives of this presentation are to provide integrated information on carbonic anhydrase enzyme, to prepare and enable you all from all disciplines to perform well in theory and viva voce examinations, and to prepare PG aspirants among you for next pre-PG examination. Now let's look at the biochemistry of carbonic anhydrase enzyme. This enzyme is called as anhydrase, meaning thereby it hydrates and dehydrates. It works both ways, hydrates or dehydrates the carbon dioxide and forms carbonic acid or breaks carbonic acid into carbon dioxide and water. The next step is conversion of carbonic acid into hydrogen ion and bicarbonate ion, that is spontaneous, non-enzymatic, and occurs spontaneously without any involvement of catalytic action of the enzyme. Now, there are many types of the carbonic anhydrases identified till date. In general, it is zinc containing metalloenzyme, and there are 5 families of carbonic anhydrases across the living beings. These families are called as alpha, beta, gamma, delta, and iota. Among these 5, alpha family is found in mammalians and humans, and others are found in plants and lower organisms. At least 15 types of alpha family members are identified as on date. Now, these are categorized into catalytic type and non-catalytic type. So let us see where are catalytic type of carbonic anhydrase enzymes located. They could be cytosolic. Examples are type 1, type 2, type 3, type 7, and type 13. There could be membrane bound in the cells, and these are type 4, type 9, type 12, type 14, and type 15. They can be in the mitochondrium, particularly type 5, subtype A, and subtype B. One of the enzyme is secreted in the saliva and milk, and that is a secretory carbonic anhydrase type 6. Among the non-catalytic types, they don't subserve the catalytic enzymatic function, but they are proteins related to carbonic anhydrase, and these are type 8, type 10, and type 11. So in all, if you look at from carbonic anhydrase 1 to carbonic anhydrase 14, there are total 15 types of the carbonic anhydrases which are found in various body tissues. For example, type 1 is located in RBCs and GIT, and in RBCs it subserves the function of carbon dioxide transport. Type 2 is widely distributed, common, and is also involved in bone osteoclast function. Now, type 3 is located in skeletal muscles where it involved in ATP generation. Type 4 again is common, located in GIT, kidney endothelium, and its main function is bicarbonate reabsorption. Type 5 and type 5 A and B are mitochondrial. Type 5A is found in liver, and is involved and participates in gluconeogenesis and ureagenesis. Type 5B is widely distributed, and recently it is located in Sertoli cells where it controls lactate production. Type 6 is secretory and it actually increases the capacity of saliva to neutralize acid and may have anti-plaque activity. Type 7 is again widely distributed, and among other functions it has oxygen-free radical scavenger activity. Type 8, type 9 and type 11, they are the proteins. Type 9 is GIT related, and actually it is induced by hypoxia, and therefore it has a role in tumorigenesis and cancer. Type 12 is found in kidney. Again, it is also inducible and it plays role in tumorigenesis. Type 13 is again widely distributed, and it may be involved in reproductive system for fertilization. Type 14 is kidney, located in kidney, heart and skeletal muscle, and serves multiple functions. Mind you, all types have one common function, that is catalytic hydration and dehydration of the carbon dioxide. Now let us look at the physiological functions of the enzyme. In RBC, it is found uh, to carry carbon dioxide from tissues to lungs. In fact, if you look at the presence of the enzyme, it is ubiquitous. It is present in all type of cells. But in certain cells, specific functions are subserved. For example, in the same token, carbonic anhydrase maintains acid-base balance, pH regulation. It's one of the important functions of carbonic anhydrase can be seen in renal tubules, and here it acidifies urine and conserves bicarbonate in the body. In gastric glands, particularly in the acid secreting parietal cells, it is involved in hydrogen ion secretion. It is also involved in formation of aqueous humor in the ciliary epithelium of eye, and it is also involved and contributes in CSF formation in the choroidal plexus of the ventricles of the brain. Among other functions, in exocrine pancreas, exocrine secretion, which is rich in bicarbonate, is because of the activity of enzyme, and osteoclast differentiation maintaining cellular pH is also carried by carbonic anhydrase in the bones. This pictorial will provide you predominant subtype present for specific function. We may remember that type 2 and type 4 are considered to be very important and very common enzymes. Example of the parietal cell where carbonic anhydrase converts the reaction in such a way that by ultimately hydrogen ion or a proton is secreted in exchange of the potassium through hydrogen potassium ATPase or proton pump. This is how hydrochloric acid is formed when hydrogen combines with chloride ion, which can freely move. In the renal cells, there are two types of the enzymes located. One is on the basolateral and apical membrane, and the second is in the cytoplasm. The cytoplasmic variety is carbonic anhydrase 2, and basolateral apical is carbonic anhydrase 4. If you look at the pictorial, it will tell you that ultimately hydrogen and secretion is a function of coordinated activity of these two subtype of enzymes, and bicarbonate secretion ultimately comes back into the reabsorption comes back into the interstitium and blood. It must be understood that direct reabsorption of the bicarbonate cannot be done, so it must be converted into carbon dioxide and water by carbonic anhydrase enzyme. So there is finally acidification of the urine and bicarbonate conservation by this enzyme. Now the pharmacology of the carbonic anhydrase enzyme, the drugs which inhibit the carbonic anhydrase enzyme are called as carbonic anhydrase inhibitors. Most of the drugs belong to sulfonamides chemically, and they inhibit the enzyme in a non-competitive reversible manner. Acetazolamide is the prototype of the drug, and earlier in 50s, sulthiam, which was a sulfonamide carbonic anhydrase inhibitor, was used in the treatment of focal epilepsy. In addition to the conventional carbonic anhydrases, we also have other drugs such as topiramate and zonisamide, which are sulfonamides, which are important drugs in the management of refractory epilepsy, and they have significant carbonic anhydrase inhibiting activity. Now, these are the drugs which can be either used orally or topically. Acetazolamide is commonly used oral agent to inhibit carbonic anhydrase enzyme in a number of clinical conditions. It has also been made available for parenteral use in some countries. Other drugs are methazolamide, dichlorphenamide, and ethoxyzolamide. The two drugs which are topical for the treatment of glaucoma in eye, brinzolamide and dorzolamide, are the two drugs which can be used alone or along with other agents required for the treatment of chronic simple glaucoma. For example, brinzolamide with brimonidine, which is alpha 2 agonist, and dorzolamide is used along with timolol, which is beta blocker. Now let us look at the renal actions of the carbonic anhydrase inhibitors, acetazolamide. Now, by inhibiting the enzymes, the drug causes electrolyte changes and increases urine formation. Now, there is an increase in the excretion of bicarbonate, and it is said that about 35% of the filtered load is removed in urine. There is also loss of sodium and potassium in the proximal tubule. The potassium loss is considered to be much more than sodium in urine finally, because sodium gets exchanged with the potassium in the distal tubule. Now, this electrolyte disturbance is also reflected in blood in the form of hypokalemia, metabolic acidosis, and hyperchloremia. So this is an unusual drug. You will remember that most of the diuretics cause metabolic alkalosis, but acetazolamide causes metabolic acidosis and hyperchloremia. Ocular effects of the carbonic anhydrase inhibitors are reduction in the formation of aqueous humor, because there is reduction in the secretion of bicarbonate, and also reduction in the intraocular tension. Now, for the purpose of reduction of intraocular tension, they are considered to be good drug for the treatment of glaucoma. Now, acetazolamide is given orally in the treatment of acute angle closure glaucoma, preoperatively also, to lower tension before surgery is contemplated. It is also useful in secondary glaucoma. And the two drugs which I earlier mentioned, dorzolamide and brinzolamide, are commonly used in chronic simple glaucoma. Now, usually topical eye drops are harmless, but stinging, itching sensation, lacrimation, irritation may occur, and sometimes corneal edema may occur. So this has to be kept in mind. In RBCs, carbonic anhydrase inhibitors will result in increased carbon dioxide levels in peripheral tissue and decreased carbon dioxide levels in the expired gas. But this effect may not persist longer, and body tends to compensate. So this is not a major effect. Now, apart from that, carbonic anhydrase inhibitors may cause vasodilatation by opening up of potassium channels, that is calcium activated potassium channels. So they cause relaxation, vasorelaxation. Apart from this, there is a reduction in the pancreatic secretion, which is because of bicarbonate is decreased, and there is also reduction in hydrochloric acid secretion. But these two effects are seen in very high doses, and therefore they cannot be used therapeutically in ulcerative disease or pancreatitis. Now, in the CNS, there are broad spectrum anti-seizure activity, and this activity may be per se due to drug, but also due to elevation of carbon dioxide level and reduction in the pH. Now, some applied aspects of carbonic anhydrase enzyme in medicine, ophthalmology, and pediatrics. Now, deficiency of hepatic mitochondrial carbonic anhydrase subtype 5A may result in hyperammonemia in early childhood. This can be an uncommon cause of hyperammonemia in children. Second is diuretics cause metabolic alkalosis in general. However, mild diuretic acetazolamide causes the opposite, that is metabolic acidosis. Similarly, we may also remember that loss of carbonic anhydrase activity in bones impairs the ability of osteoclasts to promote bone resorption, and this may lead to osteopetrosis. So, carbonic anhydrase may be involved in metabolic bone disease. The extent of caldiuresis by carbonic anhydrase inhibitors is much greater than natriuresis. This is because the sodium and potassium, which are uh, filtered, the sodium is delivered to distal tubule to a greater extent, which gets exchanged with the potassium. So net potassium loss is much more. What are the therapeutic uses of carbonic anhydrase inhibitors? At present, high altitude illness or acute mountain sickness is one. It is caused by rapid ascent over 3 kilometers, and there is cellular hypoxia and hyperventilation. Now, these manifestations would depend on the rapid rise of the ascent, headache, lassitude, dizziness, nausea, dyspnea, difficulty in concentration, auditory and visual disturbances, sometimes cyanosis, and uncommonly vasogenic cerebral edema. Treatment is oxygenation by face mask, periodic hyperventilation, and descent to lower height. Descent to lower height is very important. However, use of drug like acetazolamide decreases CSF formation and decreases CSF pH, and this may be very helpful. And this has been found to be useful in sickness per se and also prophylaxis also. And for prophylaxis, it should be taken 2 to 3 days before as 250 milligram 8 hourly. Dexamethasone, a glucocorticosteroid, is found to be very useful in the dose of 2 to 4 milligrams 6 hourly for 5 to 7 days. Other indications are pseudotumor cerebri or benign intracranial hypertension, and acetazolamide is used, but one of the drug, that is topiramate anticonvulsant, having carbonic anhydrase inhibiting activity, is alternative in this condition. Uncommon condition is familial periodic paralysis, and here acetazolamide acts by causing metabolic acidosis. However, dichlorphenamide, being a long-acting and more potent, is preferred. As a diuretic, I told you earlier also, it is a low efficacy mild diuretic, and with continuous use the diuretic activity reduces. The action is self-limiting because there is metabolic acidosis. Body tries to conserve bicarbonate, so there is little bicarbonate filtered. So no exchange occurs, no change occurs in the proximal convoluted tubule. Because of this reason, acetazolamide is not commonly used as a diuretic. However, sometimes it is a special place in the treatment to counteract the diuretic induced metabolic alkalosis. Uh, as I told you earlier, metabolic alkalosis is common with other diuretics. In the treatment of epilepsy, Acetazolamide, despite having broad-spectrum anti-seizure activity, has limited utility because of rapid development of tolerance, and the benefit are probably because of induction of metabolic acidosis and direct anti-seizure activity. It also reduces intracranial pressure. It has a role in absent seizure management, but because of tolerance, less often it is used for the purpose. There is a special use of acetazolamide in intermittent epilepsy which may occur, exaggeration of epilepsy which may occur during menstruation, and this is called as catamenial epilepsy, in which this condition it is found to be useful, and obviously it is to be used for short time only. Severe hyperphosphatemia is another indication because acetazolamide increases urinary phosphate excretion. The role of carbonic anhydrase inhibitors is being explored in many other conditions, which include Meniere's disease, nephrogenic diabetes insipidus, idiopathic intracranial hypertension, and Klein-Levin syndrome. I have discussed the biochemistry, physiology, and pharmacology of the enzyme carbonic anhydrase and its inhibitors. Some of the applied aspects concerning to medicine, ophthalmology, and pediatrics are also covered. And I am sure you all will benefit from this review. The next topic would be on phosphodiesterase and enzyme as inhibitors as an integrated topic. Thank you for joining.